All right, well, welcome back, everybody. As I said, we're going to start our panel discussion at this time. My name is DJ Betancourt. I have the pleasure of serving as the Deputy Commissioner for the Insurance Department. When Jason told me that we were going to be focusing on the public health emergency, I thought that what would be a fun experience is for all of us to predict the actual date that it will end and put the dates up on the wall. And then whoever came closest, George Roussos, would buy him an iced coffee or something like that. But Jason and the commissioner told me that we had to be serious. And so as a result, we've got a fantastic panel that's going to talk about this important issue. So to kind of get everybody on the same page, as most of you know, in late January of 2020, the Secretary of Health and Human Services declared a public health emergency in response to the COVID-19 pandemic. Since then, it has been renewed 10 times. I think the latest was actually last week, and it remains obviously in effect today. This impacts both public and private health insurance in many, many ways. Amongst them, COVID-19 testing, treatment and vaccines, Medicare, Medicaid, and CHIP eligibility, and telehealth services, as I said, among many other things. So the greatest concern regarding the impact of the ongoing public health emergency is preparing for and administering the unwinding of the Medicaid continuous enrollment provision. Our department has been involved with our state's Health and Human Services Department to put a game plan together such that when that opportunity comes, the state will be ready to engage in a very proactive and robust way. But to talk a little bit more about this morning, as I said, I have a great panel of diverse individuals, starting with Maria Prue, President of Anthem, Caitlin Skoutoris, Vice President of the New Hampshire Market for Harvard Pilgrim, Chris Kennedy, Vice President of External Relations for Ambetter Centene, Dr. Tiffany Pierce, New England Market Medical Executive for Cigna, and Caitlin McCormick, Vice President of Sales and Account Management for United Healthcare. Good morning, everybody. Thank you for being here. I'll throw this question out to the panel, understanding that some of you may not be impacted, but how is your organization preparing for the uncertainty of potential enrollment related to Medicaid redeterminations? And in answering this question, you may want to consider things like, what is your engagement? How are you interfacing with the navigators' expectations for enrollment shifts, impact on claims with the enrollment shifts, and potential network strains? So I'll start with Maria.
Thank you. I'm so excited you started with me. My only goal today was not to go first.
Oh, well, sorry about that.
I failed. Thank you for the question. I think this is a really important topic. And I think for us at Anthem, it's one of our #1 strategic priorities. We're spending a lot of time as a New Hampshire strategy team talking about this. My director of sales, Bob Benedetto, this has been almost a full-time job for him over the last few months, just understanding it. We're different from our other Anthem commercial markets in that we don't play in the managed Medicaid space. So we've been sort of sitting on the outside. So one of our key goals first was getting really educated and spending a lot of time with DHHS and understanding what the program looks like, understanding what the unwinding process is going to be. As you know, CMS is giving guidance about the unwinding process, but then at the state level, there's a lot of state level decisions that we have to make. And so really understanding what that process is going to be, and then spending a lot of time with the navigators. DJ, you mentioned the navigators. We have a great navigator organization in the state of New Hampshire. So we spent a lot of time with them. We actually have a training coming up with them so that the navigators understand our Anthem products and portfolio and network options. From an Anthem perspective, we believe, and anxious to hear the other panelists' perspectives, but a lot of the enrollment shift we expect to come on the individual side. And so we do have a robust set of products and plans and network available in individual. And so we just want to make sure there's a really good understanding of how our products work, how our networks work, what are the Anthem tools, how you access those tools. And so, that's hard to do individual by individual, but that is what our great navigators do. And so spending a lot of time with them so they understand the plans, and then making sure they understand how to communicate with Anthem, as the unwinding process starts. So I'll stop there.
That's great. Thank you. Chris, I'll throw it over to you because you obviously have an interesting perspective given your role in the Medicaid space and in the individual market.
Yeah, I appreciate you pointing that out, DJ. Obviously, in addition to the Ambetter product here, we are one of the state's 3 managed care organizations. So, we've been keenly proactive in preparing for this process. And I want to give credit here as well to the Department of Health and Human Services, who obviously we work closely with and has had the foresight going back. We really started 14, 15 months ago, kind of talking collectively about strategies and efforts, communications, message, and communication channels to members that we would know would be redetermining. We've used a number of tools. Maria mentioned the navigators, and I know Elias Asher was here from one of the navigator organizations, and we've worked really closely with Elias and his organization. Obviously, working closely with providers is really critical, and dovetailing off their credibility with patients and consumers to make sure we're getting the message out. And that message really is twofold. I mean, one, yes, it is. First, if you're still, do your redetermination. If you are still eligible for Medicaid, you can stay on Medicaid. And that's important. As we just went through the presentation to show, the population growth on Medicaid and the important safety net and in some cases gap coverage that Medicaid and expansion has afforded. But then the second part of that message is if you're going to be terming ineligible, that there are high quality, affordable options available to you on the individual market. I think we've got a real success story again that a lot of the slides we just viewed illustrate here. We have a success story in New Hampshire to tell about our individual market, and there is affordability on that market, and there is variety on that market. And so that's something we're also talking to members and consumers about as we talk about redeterminations and prepare for this process.
Wonderful. Thank you. What is Harvard Pilgrim thinking about as we face the potential unwinding at some point?
A lot. I've been in this role since July of 21, and since entering the role, I've been focusing on this public health emergency, right? This is the unheard of moment in healthcare in so many different areas. Our team has been focusing on it, and really its impact on the insurance market is just one piece of the puzzle. Obviously, the Medicaid redetermination process, to understand it, to meet with those involved, the insurance department, our state Medicaid office, hear what they're doing as part of the challenge that they have, and really how we fit into all of that. Harvard Pilgrim is in the individual market, right? Is not in the Medicaid space. And I think from our vantage point, it's important to keep in mind that there are options outside of what these beneficiaries may currently be experiencing in the Medicaid program for shopping, right? That they need to understand the options. We want to keep them insured as a community. We want to make sure they have access to the right plans. And certainly the Navigator program, as we've heard, is crucial to that. And we've been working with them on that. I also, you made mention that this may not affect others on the panel. And I would challenge us to kind of think, is that accurate or not? Because, some of the questions we're thinking about are who's currently in the Medicaid program that is dual covered? Who's also in the small group market? Who's in the large group market? No one has really contacted. Maybe they're just not thinking about what their obligations are with regard to their Medicaid enrollment. What does it mean from a claims perspective? What risk does this population bring into our collective risk pools? And I do think we need to think more broadly than the individual market about the potential impact of the Medicaid redetermination process, the time it's going to take for that to happen. I mean, it may not be just one push of a button, but I think over time we need to be mindful of what it all means and all keep an eye on our collective obligation to make sure care is affordable, accessible, and that we care for our New Hampshire communities.
Thank you. Move on from that direct question, but before I do want to thank all of you. I know that you have been involved in a number of calls that Health and Human Services has had, along with the navigators. This is going to be a real team effort. And so hopefully we can continue to enjoy that collaboration as we tackle this. So setting aside the Medicaid issues, how is the ongoing public health emergency and the uncertainty of when it will end impacting your businesses in ways not necessarily related to the redeterminations, but for example, rollback of temporary policies that may have increased fee-for-service schedules, provider contracting and treatment, things of that nature. And I'll start with Dr. Pierce.
Thank you so much. It's a pleasure to talk with you today, representing Cigna, our clients, and our customers. We note, and I'll just highlight, Cigna as a large national carrier is really ensuring primarily ASO or self-insured clients. So with that, what we're talking about here is the direct impact to employers, the direct impact to patients, and the expenses that they have. So when we think about the impact, certainly we're attentively focused on noting how there's been a shift in the mix of services. As Gorman Jens Magula had graciously highlighted, we see an increase, especially in 2021, in sick visits. Similarly, we see a spike in COVID lapse and vaccination. So those are some of the key components that we've seen as we saw the transition with the COVID pandemic.
Caitlin, let's bring you in on this conversation, if we could.
Sure. On behalf of United Healthcare, I think what Kate mentioned earlier in her comments was absolutely right, that, we all have a role to play as we come out of this public health emergency, as we look at the Medicaid redetermination. So we don't sit on the individual exchange or offer Medicaid programs in the state. But the reality is, as a lot of these redeterminations happen, many of these people are employed, and some of them by all of our, large or small group customers. And so I think, the way that we are looking at coming out of the pandemic is very much the same way that we looked at going into the pandemic, which is we need to focus on the consumer. We work with our clients day in and day out, but at the end of the day, healthcare is too complicated. So we need to work to continue to simplify it. We need to help people meet them where they are, right? So if it is someone who's coming out of a Medicaid redetermination and trying to get onto their group coverage, what can we do to make that process clearer for them? How can we help explain their benefits better? One of the big advantages that I think United Healthcare brings to the New Hampshire market is that we are a large national carrier that delivers very locally. So we have the unique advantage of spending $4.5 billion every single year on innovation. And so when we were faced in the early days of the pandemic, we were lucky to have that in our back pocket. We were very quickly able to administer virtual benefits in a very meaningful way. We expect to see that continue. So as you think about virtual care, we look at something like mental health, which is a workforce issue that employers are going to continue to struggle with in the years ahead. Everyone in this country has been through a very challenging time. Everyone in this state has been through a very challenging time. And so how we utilize those innovation dollars to continue to bring that virtual care that people want to receive. We offer the largest telemental health network in the country. And when we meet with customers and talk about their experience, we see that members want to continue to receive that virtual care. It's why we just recently launched our virtual PCP model, meaning that members can have an ongoing relationship with a primary care physician that's employed by Optum, and they can see that provider over a longer period of time. So looking at the learnings that we've had during COVID and trying to expand those into what is the workforce of the future really going to look like, that's what we're very focused on.
Maria, same question for you, but to Caitlin's point, have you found yourself having to put initiatives and innovations on hold that you otherwise would be moving forward with?
Yeah, sure. I mean, I think for us, I'd say the theme is about recovery across the board. Recovery in how we operate our business and how we work across the stakeholder healthcare ecosystem. I think if nothing else, COVID taught all of us that we can all be agile in the face of rapidly evolving change. And I think it's how we now in this new world, because I think we are in a new world. And I think, what we want to see is that we're going to progress and not maybe go back to some of the things we've seen of the past. Looking at some of the data that Jen presented, I got a little excited, like even with the ER trends. It's one indication and we have to watch it, but ER trends are back. but they're not back to the place they were in 2019. So have we done a good job working with our providers on making sure that members understand alternatives to going to the ER? You know, is that going to change now forever? You mentioned telehealth. You know, where are we going to go with telehealth? We've seen obviously a backslide on the medical side, which I think we all expected as providers figure out what is safe, what is effective in the telehealth space from a medical perspective. But I think we've seen a whole new world in the mental health space. You know, we all know we were challenged with access from a mental health perspective. And what telehealth did was it opened up access for members across the state who really need mental health care. And we are not seeing a backslide in the utilization of telehealth for mental health services. We're seeing it continue to increase. And so for us, DJ, you know, it's about recovery. And, you know, when we look at what we wanted to do, does it still make sense given this changed marketplace that we're in? You know, another thing in the data that Jen presented is the use of primary care. You know, going back over 10 years, Anthem launched a program solely focused on increasing the use of primary care. So to see it showing up in the utilization numbers is very positive. And I think, you know, even the comment from Paula about people showing up sicker, maybe as a result of the pandemic, I think we all have to take a step back because it's on us to make sure that we're continuing to encourage the use of primary care. That is what prevents those members from showing up sicker. So we know that people didn't go because of the pandemic, but we have to work together to encourage them to return to their primary care providers so we can catch things earlier. So they're not sicker when they're showing up in the inpatient setting. And I apologize, am I whacking you with my pen?
I have a toddler, so you know, all the time.
Yeah, and then
We'll make sure to rent a larger table
Yeah.
next year.
I'm like, and then I think it's addressing the other trends in the market, all right? We know we are an aging population. We're the second oldest state in the country. We have to address that. All of us collectively, payers, providers, we have to address that. We have to make sure that we're dealing with that in the state of New Hampshire, because that's going to continue. And if the trend is going where we think it's going, we're going to be the oldest population, surpassing Maine very soon.
Chris.
Yeah, I'm going to touch on, you know, many of the same topics Maria did, and not to be redundant, but I think a couple of them are really salient. You know, telehealth is a lot, something we've been thinking about a lot, and the enhanced familiarity, both on the consumer side, but also on the provider side, the willingness to utilize telehealth and expanding our platforms there. You know, we introduced a virtual network product that I think can really capitalize on that. And as Maria touched on as well, you know, could really be a tremendous tool in terms of expanding access, especially in New Hampshire's rural areas. Incentive programs is something we've been working on in the last couple of years. And obviously we know things like preventive screenings, you know, wellness visits have been down, that type of utilization has been down over the scope of the pandemic. So working with incentive programs to think about how we can encourage members to get back and utilize those important access points to healthcare. But also kind of at Centene and at Ambetter, doubling down on kind of our bread and butter, what we do, care management, care coordination. If we do see bottlenecks in kind of provider access, care access as we're emerging from the PHE, making sure that we're working closely with providers with care management and care coordination and triaging people to the right center of care at the right place at the right time. I think that's going to be critically important.
Catherine, round things out.
You're just turning right to me, huh?
I figured this is a natural flow to this.
No, that's great. So all of this is really important. The impacts of the public health emergency ending, right, range from the cost shifts that we need to keep an eye on, right? So the cost of the boosters, the vaccines, what, you know, COVID-19 has brought to healthcare. I think all of us are kind of just uncertain of what it's going to look like. It's going to be there, but sort of how the trends work with seasonality, what the cost is going to be, you know, cost is top of mind for everyone, not just those in the direct, you know, business of healthcare, but all of our community, and in particular for us, you know, our employer community. You know, we are the gateway for them to provide care to their employees. And more than ever, we're hearing the cost, you need to help with costs. They have inflation concerns. We have inflation concerns. We have workforce shortage issues. So do they. You know, we've been hearing a lot about it from our providers lately in the news. It's not any different for any other business. And so how are we going to pull together to make sure we're doing what's right, you know, for the cost of care, access to care, the quality of care, and continuing to get those options out there without, you know, inundating healthcare with all of the costs that could potentially come with that. You know, we're being looked at by our provider community to help them recoup the costs of all the losses of COVID. We are continuing to pay back rebates, as we saw through the MLR rebate process. We're going to have this cost shift, and there's more demand for care than ever. And the severity of the care, I think, has increased. So there's a lot of challenges that we need to come together to try to solve. So we're in this more than I think just in the calculating of a health plan option. You know, we have all of the workforce issues coming at us. We have inflation, and then of course the scary recession term that everyone's panicking about, right? Rightfully so. And what do employers want to do is not spend more to help their employees get care. So.
Chris, did you have something?
Yeah, I mean, Kate mentioned workforce, and I don't think you can touch on the challenges we're confronting as a broader healthcare stakeholder community without talking about workforce. It really touches every aspect of not only access to care, but cost of care, right? As hospitals and providers are relying more and more on things like traveling nurses, that increases labor costs, that filters through the cost system. But, you know, I read a report, I think just in the last month from, I think, Bain & Company that said 1 in 4 clinicians nationwide is considering leaving healthcare in the next year. And a lot of them cite burnout, obviously, which is a byproduct of the pandemic, right? And the intensity of the pandemic. And, you know, I know there are a lot of good conversations being had at a public policy level in New Hampshire. There's a lot of interesting partnerships and work going on in places like UNH and the community college system. But, you know, I think it's incumbent on all of us as healthcare stakeholders to really be contributing to that conversation. I'm not going to sit here and say I think health insurers, you know, can offer a panacea, but I'm certainly going to sit here and say we have a role to play in that conversation. And I think it's incumbent on us to do so.
Well, you all have done an excellent job of providing robust answers thus far. I'm able to skip over a couple of questions, but any impact are you anticipating related to enrollment or market stability as a result of the ARP subsidies or CMS's attempt to address the family glitch? And I'll ask for a volunteer on that one rather than putting you on the spot. Uh-oh, is somebody going to get voluntold? Chris, I'm going to you.
Okay. Well, you know, I'll just say from an individual market perspective, again, I think New Hampshire has a success story to tell. We touched a little bit in Jen's presentation on the reinsurance program and the way that has helped bolster and stabilize the individual market. You know, that's not a coincidence. That was a very purposeful public policy decision. You know, again, I sit on the New Hampshire Health Plan Board, and I know Kate does too. And we spend a lot of time making sure that program is achieving what it was set out to do, which is lower premiums and stabilize the market. And I think we can check both those boxes in the short term. I'm gonna divert by your question a little bit, and of course the Medicaid guy is gonna go back to Medicaid for a second. But I think since this is my third time around, I'm going to take that personal privilege. Medicaid expansion is something that we're thinking a lot about. And of course, we're a bit of an anomaly here in New Hampshire. We have a sunset on our Medicaid expansion program, referred to as the Granted Advantage program. It is currently, I believe, scheduled to sunset at the end of 2023. Critically important decision for the legislature to take up this year. And I'll just say critically important for the legislature to reauthorize that program and maybe make it permanent so that we know there's that continuity of care and coverage for that population that we talked about is now approximately 17% of overall covered lives.
A very good point, Chris. Thank you. Others, ARP subsidies, family glitch. Who's got thoughts?
I mean, from an Anthem perspective, just to answer sort of your basic question of do we have concerns? We don't. I think, one of the things about New Hampshire that I think is a bright light, in addition to some of the things you just mentioned, is I think we do have a stable market. We have a market that has a provider community that has stepped up to support all of our members across the board, our Medicaid population, Medicare population. So as we take on more from an enrollment perspective, I think, we feel confident that the market is stable, and wherever the enrollment shifts happen to be, wherever the subsidies push the market one way or other, I think we feel pretty confident that we'll be fine. And I do think that, some of the trends we're seeing again, in some of the data that was presented earlier are interesting. And I think we have to continue to watch it and react to it. And by that, I mean, we see a general decrease in enrollment, although stabilizing a little bit in small group. Where are they going? I think Paul asked that question. We see the ASO piece was a little interesting to me, seeing a decrease in ASO because we see a general increase just in our population. And then from a large group fully insured, we definitely see a decrease. And I think, one of the things that we all have to be mindful of as a market in general that we have to talk about is consolidation and mergers and acquisitions. Because I think one of the dynamics we've seen in this market over the last couple of years is many companies being bought up by larger out-of-state companies, which is pulling some of that New Hampshire situs business out of our state. And so from my perspective, when I see the decrease in enrollment across segments, that's where I go to first. And so if we have less of a population to cover, that has significant implications from a risk business perspective. So I think that's certainly a trend that we constantly watch. And I think as a state, we have to watch.
Thank you.
I'll just add, I couldn't agree more on some of the insights that you drew from the update that we just got from Gorman Actuarial. I mean, the self-insured large group decrease is puzzling, and it matches what we've seen, which is the mergers and acquisitions, sort of the attractiveness to sell your business to an entity outside of New Hampshire that has health insurance options that they can provide. The other thing too is, last year we focused on the small group market, and it's, troubling to see it's continuing to reduce in size. And as we think about subsidies and we think about options that are available potentially in the individual market space that is not in the small group space, what population of small group employers are saying employees go into the individual market. I think we just need to be mindful of all of these dynamics when the individual market is getting all of this attention and all of these subsidies and things that potentially for New Hampshire, right? This small group, 63,000 lives, it's within its own pool. It's something that I'm mindful of we want to be careful that we don't disintegrate the size of that to the point where the risk becomes unmanageable.
Thank you. And that actually is a perfect segue into our last question. We're at our last 15 minutes here. And that is, broadly speaking, as you look at the market, what are the things that concern you, or what are the things that intrigue you? Interestingly enough, last week, we got a call into the department from a small municipality in New Hampshire who was very anxious for the rates to come out because they're actually, for their employees in this small town, going with the ICRA model. And I'm wondering how that innovation might play out. And so it doesn't have to be ICRA, but what are those things that you see emerging that either, like I said, intrigue you or perhaps concern you? And we'll start with Dr. Pierce.
Thank you. So certainly, that we're not in the small group market, so that's going to impact my reflections there a bit. But when you look at and say, what is the opportunities that we see? I think we see a lot of opportunities for innovation, especially as we think about the value-based space. We've used the COVID pandemic as a catalyst to really say, how can we partner more attentively together with the provider community? What are those opportunities, for instance, to be improving preventative care, including cancer screening in partnership with the provider community? Our focus together on chronic conditions, screening, treatment of behavioral health conditions, And as the pandemic has highlighted for all of us, we see that huge opportunity as we think about health equity and social determinants of health. Most of you probably know, but as a clinician, when you hear, wait, the number one opportunity is access to food, this is an opportunity for all of us, together with the provider community, together with the community at large, to be partnering together. And I'd be remiss, of course, if I didn't mention behavioral health and the opportunities there. We see such an important opportunity to more attentively focus together as a community and as a provider community in partnership together around behavioral health. And so Cigna has looked not only to work with the provider community very attentively, that's here wanting to see people in person or actually pivoting. About 60% of those services were seen as virtual, but also partnering with a number of virtual vendors. Most of you probably know Cigna purchased MD Live, a virtual 24/7 provider of care. This has been a benefit to our Cigna customers. It's also been a benefit across New Hampshire, as many of the providers have directly partnered with MD Live as a resource for their patients. So we see the opportunity really to continue to look for creative ways, innovative ways to provide better care for our customers.
Wonderful, thank you. Caitlin?
Thank you. Yeah, I think as we think about, the future, we're very focused on the challenge of helping employers offer benefits that are really valuable to their members. So if you think about a high deductible health plan with a $5,000 deductible, for the average New Hampshire worker, that they often don't see any value in that benefit, right? It's the second largest, healthcare is the second largest expense on a company's bottom line after payroll, yet a benefit plan that most of their employees will never get to utilize because of the deductible level isn't seen as a benefit, and it doesn't help with the workforce challenges, and frankly, it doesn't help people live a healthier life. And so what we're really focused on is, one, around benefit design, helping design benefit packages that truly are appealing to members. We have a new innovative product out that is actually an episodic-based copay plan that doesn't have any deductibles, where members know upfront through an app exactly what they're going to pay for their entire episode of care. Because we're able to give members a national footprint and national access, that plan actually saves up to 15% over a like plan that might look like it in a more traditional module. So we're focused on that benefit design that's going to help drive value for employers first and foremost. And then also looking at that low acuity, the self-care, the things we talked about around virtual, but even taking that a step further. So what are things that people can do to keep themselves healthy? What are benefits that we can give to members that they can use at home, right? Things like giving people a subscription to Peloton or to Apple Fitness, offering one-on-one weight loss coaching and covering it through the insurance plan. So what are things that the member is actually going to value from, even if they never hit that deductible and they never have to use the true pieces of their plan? What are the things that their employer can show up for them for and show a lot of value around?
Thank you. Before I throw it over to Catherine, I was remiss earlier in not saying that if the folks who are joining us virtually have a question, feel free to post it. Andrew's keeping an eye on it, and we'll get to them as soon as they come in.
Thanks. And at Harvard Pilgrim Healthcare, we, saw the benefit of launching virtual plans almost immediately after the pandemic had kicked in. We wanted to provide more access. We're excited about that. And we see a real future there, as we've heard from the other panelists, particularly as patients think about how to get care when they want care, and the, trouble scheduling appointments and getting more access to care. But we're also a nonprofit health plan. And so we have a mission to build and care for healthy communities. And we've been long in that discussion since the start. So one thing that's exciting to see is the focus on behavioral health, right? So we've always been a whole care, whole person health plan option. We want to make sure those pieces are connected. It's, mental health is healthcare. And so the pandemic has really brought that to light. We've really seen the needs of our members and our communities in getting behavioral health services, whether it's mental health or substance use treatment. And so we're glad to see that conversation happening, as well as rural health. You know, rural health is a big piece and it's an important piece for New Hampshire. Through our nonprofit foundation, we've launched this mobile health clinic up in northern New Hampshire. And really it's for the community because we're a nonprofit. It's not for members. They can use members, but it's not limited to members. And the goal is to increase access in our rural-most parts of New Hampshire. You know, half of the hospitals in New Hampshire are critical access hospitals. So we have to keep in mind our obligation to care for our communities as a whole. And that's one thing that Harvard Pilgrim just does really well.
Wonderful. Thank you, Chris.
Yeah, I just, you know, on the opportunity side of the equation, you know, obviously not to be redundant, but telehealth and the opportunities there, again, given the acclimation of not just patients, but providers to telehealth. And the cost side of the equation, value-based contracting and talking to providers about how value-based arrangements can offer some predictability and stability, given what we've just kind of collectively been through. You know, on the concern side, I mean, I've shot this arrow, but I'm, you know, workforce and specifically within that substance use disorder. You know, the state of New Hampshire has been disproportionately impacted by substance use disorder. You know, our experience with the Medicaid population as a population that's been disproportionately impacted by substance use disorder. We see, you know, overdose numbers going up, especially in New Hampshire's largest communities. It causes concern. One of the things we've invested in at New Hampshire Healthy Families and Better is a workforce program around CRSW, Certified Recovery Support Workers. These are peer-to-peer workers. A lot of literature to support that are quite effective, especially in the SUD space. We've made an investment in provider institutions like the Tilton Family Resource Center, where we're sponsoring applicants for CRSW certification. We're paying for, you know, their curriculum, their training, their materials, their exam fees, and then they're able to do their supervised clinical hours under our clinical staff. We started that program in 2018, 2019. To date, we've had about 20 CRSWs go all the way through to completion and get their certification. Seems like a small number, but when we started that, I think there were only about 100 CRSWs in the state of New Hampshire. So, you know, it's a start and it represents important progress, again, in an area that I think we're going to be confronting in New Hampshire for some time.
Thank you, Chris. Round things up, Maria.
Great. So, you know, I think from my perspective, it's really, you know, coming back to some of the data that we saw and heard today and the data that we look at Anthem on a day-to-day basis and how we react to it, hopefully in the post-pandemic world. And I think, you know, it's also on the themes that we've heard today is meeting the members where they're at, right? It's very clear from the data that the number one driver here is healthcare costs, the cost of actually providing members with health care. And I think given that, how do we control those costs and not limit access? Right? We want members to do certain things. We want individuals to seek healthcare. So how do we meet those members where they're at so that it encourages them to seek the care they need and discourages them from seeking unnecessary care? And I think it's a combination of what everybody said on this panel. You know, we've talked a lot about digital innovation, telehealth. From our perspective, we have to be able to leverage telehealth, but telehealth is never going to be a substitute for our in-person provider network in this market. We need our in-person provider. So we have to find a way to encourage the use of telehealth while also making sure that we're maintaining the foundation of our in-person provider networks. You know, the access on the behavioral health side is fantastic, and we need to encourage that because I think we've seen more individuals using behavioral health because we've given them an alternative way to seek that care. On the medical side, we're going to have our in-person provider network, and we need to make sure that we shore that up as we come out of this pandemic. And I think so making sure we use digital. The other thing is, as you've probably seen with data, is how do we make sure that we're all connected from a data perspective? So, we have a statewide contract with Collective Medical that provides real-time, ADT data, right? And we have been working with our providers on how are they leveraging and accessing the use of that data so that when their patients are showing up in another ER, they get immediate access to that data. Again, that allows the provider to manage the care of the member. And it comes full circle to the discussion around value-based care. I was surprised by some of the data around value-based care. I would have thought to see an increase because I know from an Anthem perspective, the majority of the relationships we have with providers are either upside only or upside and downside. And that's across all of our segments of business. We don't pick and choose when we go into value-based care. And so part of helping providers be successful in those arrangements is making sure that we're giving them access to data about their patients that we might have, whether that's because they're using all of our telemedicine tools or for another reason. Finally, the last thing I will say, because I think we haven't talked enough about it, and it was the #1 driver of trend, specialty pharmacy. So we cannot ignore the trend of drug, right? These are life-saving drugs that any one of us would want access to ourselves, and we want our families to have access to them. But we have to watch that trend carefully. And I'm very proud to say that over the last 18 months, we've partnered with our providers in this community, looking at specialty drug and the costs and trying to bring those costs down over time. I think that will be a key area of focus for us as we move over the next 12 months as well.
Wonderful. Thank you. Andrew, have we had any questions come in?
Yeah, there's kind of a two-part question. The first part is asking what you all have done to invest in primary care and what you've done to help members access primary care over the last year. The second part of that is asking if you could talk about how you're partnering with health systems to address the cost issue.
I'll take volunteers. Who would like to tackle this one?
I'll start on that one because primary care, as I said before, it is a passion of ours at Anthem. We launched a program in the state of New Hampshire well over 10 years ago called our Enhanced Personal Healthcare Program. It was a very specific decision we made at Anthem, looking at the provider landscape in New Hampshire and understanding the impact that primary care has on the overall spend. I think we all acknowledge that primary care spend in and of itself is small, but it controls, when you look at that funnel, most of the downstream care. And so we set out over 10 years to start partnering with our primary care providers in New Hampshire, where we put them initially in an upside only risk arrangement, where we said, all right, we've got to start slow. We've got to put you on a glide path when you go into risk. Providers aren't always ready to go full upside downside. That's fine. So we put them in a glide path and an upside only risk arrangement that said, we're going to pay you more for the time that you don't necessarily spend in the room with the patient. So all the things that providers do outside of the 15, 20-minute appointments. And we've had that program in place, and we now have over 85% of our primary care providers in the state in that enhanced personal health care program. We've done a lot more in response to the question. I'll pause, give somebody else an opportunity to speak.
Yeah, I'll just weigh in on the primary care piece as well. So, I think we've all done a lot over the years to grow our PCP networks and work with PCPs in the state and make sure that we have broad access. But the reality is that access is still an issue, right? We ask people to be in gated plans. We ask people to let their PCP guide their care. But if people can't get an appointment with that PCP, it's very hard to adhere to those benefit plan guidelines. So what I mentioned earlier about our virtual PCP network that launched in July, we're really excited about that. And we think I would agree with Maria that it's not going to completely replace in-person primary care at any point. That's not the objective. But there is something to be said for having access to someone who can help guide your care and who can help refer you to in-person care when you need it, and having that availability and giving people that additional resource. So I would say that, we're continuing the boots on the ground efforts and the work that we do with our traditional brick and mortar PCP relationships, but we're also focused on this virtual approach that is hopefully going to increase access over time.
Any other thoughts?
It's Dr. Pierce. I guess I would just affirm how we've really attentively focused on those value-based relationships as a key way to really facilitate better care. Those doctors know their patients best, and they can be the ones that are really attentively helping to get people in for preventative care. During the pandemic, we've seen challenges with people getting in for mammography, young children getting in for their vaccinations. They have been our key partners in working together, sharing the resources together and investing in them to be able to see changes in the way that we're delivering our care for our customers, such that initially a dip, and then as we work together, we've seen success in getting that care. So we've continued to invest in those value-based relationships and remuneration for the results that they're achieving for our Cigna customers. Certainly, I note your point about access in New Hampshire in total. And we do see the virtual resources like the MD Live certainly building out, especially around the challenges with behavioral health during the pandemic. We have a whole suite of resources there also to be able to really provide a supplement and a resource to the resources that are here in New Hampshire. But once again, we see that opportunity focusing together with the primary care physicians as the key way that we're going to achieve success for our Cigna customers and really the patients across New Hampshire.
Thank you. We're at time, but
We're out of
Chris, you
time.
want to
All right,
jump
all
in?
right.
Go for it.
Well, really quickly, DJ, I was just going to add, incentives are something we've seen a lot of promise in encouraging primary care and interaction with primary care. We have a program called My Health Pays where we actually issue members what looks like a debit card. And again, it's informed a little bit by our Medicaid experience, but we'll incentivize things like your annual physical and various wellness checkpoints along the way at primary care. And if you meet those checkpoints, then you get $25 uploaded on your what is a debit card that you could use at various healthcare costs and institutions. So I think there's a lot of promise there. Again, we talked about encouraging primary care.
Thank you very much. So to the commissioner's great relief, we're at times such that I have no more opportunities for jokes. But in all seriousness, thank you very, very much for the discussion today. Obviously, we focused initially on the Medicaid unwinding in the pandemic, but I'm glad we got some insights into a number of other areas as well. So thank you all very, very much. I'll turn it over to Jason. Great. Thank you.
Thank you all very much. That was wonderful. DJ, great job. Thank you. So we're a little early on schedule, which is great. We will, at this point, we can enter the official public comment period. Talk a little bit about the public comment process. You will be able to submit written comments to Andrew up to November 3rd. You could also, if you want to submit comments just for the record through chat, you may do that. If you want to raise your hand and submit a public comment, you may do that. And if you really want to through Teams, you can raise your hand in Teams and speak your comment. So this is not traditionally a time that takes very long, but here we are. If anyone has a public comment, please let me know. Andrew, if you find anything through chat, please stop.
Yeah, there's one more question. I don't know if it's proper to address that now.
Sure.
The question was about a convenient MD pilot program on the Seacoast, whereby they're including primary care services alongside current urgent care and other services. And the question is, do we think that will be expanded to all of the state if that pilot program is successful? I don't know.
Any carriers familiar with that particular program?
Yeah, we are. Yeah, I think, this is a pilot program that Convenient MD is launching, and I think we're excited about it. I think we just talked about access issues from a primary care perspective. So having more primary care in the state, it is not a bad thing at all. So I think whether or not it will expand depends on their business model and whether they want to expand it, but we're certainly excited to see it launch.
Thank you, Maria. Any other comments?
None so far?
Anyone else? Paula,
Thank you.
of course.
Paula Minahan Hospital Association. I was actually hoping to ask our panel some questions, but maybe we can do that this way. One has to do with what their thoughts are on population health. The hospitals in New Hampshire are very engaged in population health. And that that's very expansive relative to a lot of non-traditional healthcare services that are really, they're partnering with their stakeholders in the communities, including trying to help them with housing and services for food, as well as community health workers is something that is traditionally not covered by insurers, but something that we believe is really, really helpful in ensuring that the patient is getting all the services that they need to keep them healthy. And maybe it involves trying to connect them with childcare so that they can work, and with food stamps so that they can provide healthy food options for their children. So I would love to hear from the carriers if they are talking with the providers about community health workers, because hospitals employ them. We just unfortunately do not have any reimbursement for them. So, and then I just want to make a comment about telehealth. I was very happy to hear all the positive comments about telehealth. We are 100% supportive of telehealth. We were very involved in the passage of the parity bill back in 2020, and telehealth is one of our #1 priorities to continue to see that. And I would just, I would challenge the carriers a little bit. Behavioral health is not the only telehealth model, and we have a lot of specialty, telestroke, teledermatology. We have, there are a lot of models in New Hampshire relative to telehealth that the hospitals have made a huge investment in, and we do not want to see that go away, because it is, as I think Kate and I think Maria said, it is about access. And for our rural communities, it is imperative that we continue to have telehealth.
Great. Thank you for your question and your comment. Any carriers want to take on Paula's question? Start with Kate.
I think I touched on that a little bit about Harvard Pilgrim's nonprofit mission, and you heard the rural health clinic up there.
Yes.
We've also had several pilot programs with our local providers about food as medicine and how can we, impact the community, food insecurity, things like that. We also, all of those are driven towards supporting the community. We have a lot of grant programs through our foundation designed to support the community. And we hope to be in all the conversations to move that forward, because of course, access is important. So is the cost of it.
Dr. Pierce.
Thank you. So I appreciate your question, and maybe we did use different language a little bit. But through our value-based relationships, it's all a population health model, and inclusive and attentively inclusive of equity, the opportunity to address those social determinants of health and funding for them to be able to be working on these initiatives. So we're certainly appreciative and recognize the value of those opportunities as well. Similarly, Cigna Foundation is attentively focused on investing in the local community, and what works really well with New Hampshire Food Bank to make sure that we're providing those services. So not perfect. It's something that all of us as a community, as a clinical community, are working on together.
Anybody else? Thank you very much. And any other comment? All right. In light of that, I'll remind you that you can submit written comment through November 3rd to Andrew. Thank you all very much for coming. It's been a joy, and looking forward to it next year. Thank you.